Good evening, and thanks for joining us for this evening's clinical update on pediatric psychotropic drug guidelines. We're pleased to have an expert and one of the authors of those guidelines to present tonight. Dr. Sara Coffey is interim chair of the Department of Psychiatry and Behavioral Sciences at Oklahoma State University's Center for Health Sciences. Following her graduation from the OSU College of Osteopathic Medicine, she completed her adult psychiatry residency at the University of Chicago and her child and adolescent psychiatry fellowship at Harvard Medical School's Cambridge Health Alliance. In addition to her role at the Center for Health Sciences, Dr. Coffey serves as Director of Clinical Operations for the Division of Child Welfare of the Oklahoma Department of Human Services. Dr. Coffey has no financial disclosures in relationship to this presentation. Will you please join me in welcoming her?
Hi, thank you, Sherry. And thank you all for spending your evening with us on this Tuesday evening. We were just talking here about many of you might have your own children that are going back to school or perhaps have already started. And so certainly as a child psychiatrist, the kind of lull of the summer that we often see does seem to pick up during the school session. And so I'm really happy to be here with you all today to talk a bit about some of the child psychiatry diagnoses that you might see in your clinical practice, as well as give you some updates of some really wonderful resources that are available for you here free in Oklahoma that I'm certainly very proud of to be a part of, have utilized myself, both as a child psychiatrist and in encouraging family medicine, pediatrics, and others to call into, and something that I have the ability to be a part of that I'm just really excited about. Oops, and I'm going the wrong way. I should know. Adrian, this is all me. This is user error. Adrian told me how to use this clicker and I did it the wrong way. We even practiced. So let's talk about learning objectives today. So again, I want to talk about some of the major tenets of psychiatry in children and adolescents. Extend my gratitude to you all that are taking the opportunity to treat children and adolescents in your practice. The reality is that even our ACAP, or American Academy of Child and Adolescent Psychiatry, states that there'll never be enough child and adolescent psychiatrists to meet the need. For those of you that are perhaps in training, that's always a good opportunity to go into child and adolescent psychiatry. But certainly for those of us that are in the community treating children, I know it can be hard to get a referral in. And so as much as we can keep patients and the patients that are in medical home, we really want to be able to do that. The reality is that those of you that are caring for children and families have been working with families for sometimes multi-generations. You as the primary care provider can do a wonderful job of diagnosing and treating in the clinic. And then you can refer to us, your child and adolescent psychiatry colleagues, when it really does get diagnostic clarity issues or when it becomes very complicated. But we also have many consultative lines and other ways to support you. We also know too that in rural communities, goodness, it's so hard to find a child and adolescent psychiatrist. So I'm hoping today is to give some clinical pearls, some updates about how you can support children that are coming in to see you in your primary care office. We'll review some of the diagnosis and treatments of some common psychiatric disorders. Certainly, if you guys have questions, I want to allow some time at the end for some questions. And then, as I mentioned, we'll learn about some available consultating programs for primary care clinicians here in Oklahoma. Okay, so let's talk about some key points in psychiatric treatment of children and adolescents. And I really, this is something that does come from our resource guide, and certainly something I think is important for us to recognize whenever we're treating children and adolescents. And certainly if you are somebody that's taking your own child for mental health issues, I think it's important for all of us to have this understanding whenever we are treating children and adolescents with mental health diseases. The reality is that the first line of treatment for the majority of psychiatric illnesses really should be behavioral therapy. And this is a really important tenet. The younger the child is, the more important that therapy is there, and the more important that there is caregiver involvement. Ages ago, we used to often think about the individualized patient. So the child has an issue and we're going to send them away to get treatment, and then they're going to come back and everything's going to be better. The reality is that children grow up in an environment with their caregivers, whether those caregivers be their parents, grandparents, foster parents, or the school system. They're relying on their grown-ups to be able to kind of set the tone, to have appropriate responses, and to kind of guide them in modulating their emotions and how they're feeling. And so therapy really is a key treatment for many of our children. I say that with a bit of a caveat too, because I know the reality is that there are many therapists across the state with varying degrees of training. And so when we're referring for therapy, we really want to make sure that it's evidence-based. And I think as a primary care doc, you really want to make sure that whenever you're referring, that you're checking back in to see that improvement is occurring. Because the reality is that quite often we might make a referral with best intentions, but because therapists have varying levels of training, sometimes even to the best of their ability, they might be missing the mark. And so the guidelines too will talk about specific therapy that can be very helpful for children. And again, I just can't stress this enough. Ask about if the caregiver is involved. It is so common for families to come into my practice that the child has been in therapy for 2 or 3 years. The parent can't tell me at all who the therapist is or what they're doing. That's a problem. I want to make sure that we know what the goal for treatment is. I want to make sure that the caregiver is involved. And certainly if you're referring somebody, we have wonderful consultative lines that I'll tell you about at the end of this presentation that you can give us a call up and say, hey, I have this kid with anxiety, with ADHD, where do I refer them to? And our team will guide you with an appropriate therapy referral. The other thing too, if you are going to start medication, and I don't want to say that medications aren't effective, they are very effective in treating children. We want to start low and go slow. And so certainly, you guys know I'm preaching to the choir here. Children and adolescents are not just little adults. They have different pharmacokinetic properties and how they're metabolizing medication. They're much smaller, or they might be much bigger, but they might be metabolizing different. And so we really want to make sure that we're starting at the lowest possible dose and then titrating it to symptom remission. I think a good rule of thumb too is that we really want the lowest effective dose to be able to treat the symptoms. Not uncommon that we're going to have side effects with medications. And so I'd much rather start low and go slow and get there rather than giving too much of a medication, having a side effect, and then really kind of losing the opportunity to use that medication to treat anxiety or ADHD or other psychiatric illnesses. The other thing too is that we want to avoid polypharmacy if possible. And I will offer to you that certainly as somebody, as Sherry mentioned, I work with the child welfare. I'm also the behavioral health director for the Health Access Network. It's not uncommon that I'm consulted on children that are having a lot of struggles with a lot of polypharmacy. I think that's something that I know often comes into your all's lap too. It's not uncommon that I'm staffing kids with pediatricians, family medicine docs that are inheriting kids that are coming with polypharmacy. I hear you. It's like, what do I do now, Dr. Coffey? Again, call that consult line to get some guidance of it. I know quite often polypharmacy seems to start here in Oklahoma in the inpatient hospital, quite frankly. And we want to avoid it as much as possible, but also recognizing too that many of our kids' comorbidity is the rule rather than the exception. And so they might have a diagnosis of ADHD and anxiety and perhaps depression. And so now what do we do? So although we don't want to have polypharmacy be the rule, we certainly want to recognize that some kids might need a few medications to target those symptoms in those disease states. And we'll talk a bit more about that here moving forward. The other thing too, I think is real important is that we certainly want parental consent of medications, but I also want the child to know why they're taking the medication. It's important for me for them to know that it's helping them to feel better, that they're not having problems with it. So that child assent is really essential to care. They need to know why they're taking their medications. It gives them a sense of agency, and we certainly want to make sure that we're not stigmatizing or shaming medication, that it's really intended to help with the symptoms that they're struggling with. And quite frankly, many kids that are coming to see us are telling us, oh yes, this medication helps with my worries or helps me focus more, helps me to feel better. If a child is telling me that they don't feel like the medication is helpful and it's having side effects problems, I certainly want to have a conversation with the youth and the caregiver up in the school to make sure that things are going okay. And then with that, certainly making sure we're monitoring for side effects so there's no concerns with the medication. As I mentioned, children metabolize quicker. And so it's not uncommon whenever I'm training my adult psychiatry residents, they might ask why I'm doing BID dosing for a medication that might be on a daily basis with a grown-up. And quite frankly, some of my children that I see might need BID dosing because it feels like it's too much in one take. And so keep in mind too that quite often a trick that you might have up your sleeve, if they don't seem to be tolerating, let's say 50 milligrams of Zoloft for their anxiety, you might want to consider breaking it up into 25 milligrams BID and see if that makes things better. Again, slow and steady wins the race, and sometimes mild changes can be helpful to target the symptoms you're struggling with. Okay, so let's talk about ADHD. We are getting ready to start school. You are going to be seeing a lot of kids coming into your office with ADHD, not to mention TikTok and other social media where there seems to be a diagnosis du jour. ADHD is probably on there. We're certainly seeing that a lot in our adult clinic now, people self-diagnosing with ADHD. ADHD is certainly common in pediatric patients, but we also want to make sure that we're not missing other diagnoses as well. And so I want to give you some tips and tools for how you might diagnose this in your clinic. Again, ADHD is this persistent pattern of inattention and or hyperactivity, impulsivity that interferes with functioning or development as characterized by inattention or hyperactivity. I think the big thing for us to be mindful of too is that it interferes with functioning, right? I know I'm preaching to the choir here for those of you that work with children and adolescents. Goodness, I break that up into children and adolescents, but you all know we have infants and toddlers, preschoolers, school-age kids. And what we might expect for attention of a 2-year-old is going to be much different than a 17-year-old. So always having that developmental lens in mind, recognizing too that kind of depending on the child, they might have kind of different degrees of how they're functioning. And we certainly want to make sure that there's functional impairment in more than one setting. So if a child's coming in and they're just having difficulty in their math class, but everything else is going okay, we might have some more concerns about an underlying disorder in mathematics or something else that's going on there. This is the criteria that you can see here. Again, really pulling from the DSM for both hyperactivity or inattention. You want 6 out of the 9 that are testing positive for concerns with attention to detail, sustaining attention, listening when being spoken to, following through on instructions. And you can see the list here as well. Hyperactivity is the same thing. We're wanting 6 or more, kind of quoting positive. And there's a lot of ways to do this kind of evaluation in the clinic. I'm a big fan of non-proprietary rating scales to be able to do this. My favorite is certainly the Vanderbilt, which I think is going to be coming up here pretty soon. And gosh, Adrian's thinking, what am I doing over here? So the Vanderbilt, I think, is a really great rating scale to use. Again, in my office, I'm going to be sending this both home with the student to go to school, as well as having the caregiver do this in the office as well. You can see here, whenever it's rating it, it's wanting often or very often is indicated as a positive response. And you're going to want to see that this is going in more than 2 settings as well. The Vanderbilt's nice because it's also screening for other comorbid diagnoses that we might see. When you're worried about ADHD, also be on the lookout for oppositional defiant disorder. These two can occur at the same time, but we know that the treatment is going to be different for either one. ADHD certainly does have a more effectiveness with medication, but if the child also has oppositional defiant disorder, we're going to want to make sure that therapy is also in place that includes the caregiver. So again, I think the Vanderbilt is a wonderful scale to use. You can find it online. It has the parent information as well as teacher information. And there is also kind of updated Vanderbilts that you can send once you start medication to kind of make sure that the child's symptoms are resolving and that there's no side effects with the medications that you might choose. Okay, so going back over this way too, really when we look at the DSM, the diagnostic criteria for ADHD really means that symptoms are occurring before the age of 12. The most recent iteration of the DSM moved that up a little bit higher to 12 years of age. It used to be even younger. And for those of you that see adults, I can guarantee you that you're probably seeing a lot of adults that are coming in with adult onset ADHD. That's a different topic for a different day. But certainly keeping in mind that we typically do see ADHD come into play before the age of 12 years of age. As I mentioned, 2 or more settings it needs to occur in, and it does really need to interfere with functioning, reducing the quality of social, academic, or occupational functioning in order for us to make a diagnosis. Sometimes you'll likely have kids that are coming in that you're not quite sure if it's ADHD or not. ADHD can certainly be diagnosed in the primary care clinic, can certainly be diagnosed by a psychiatrist as well, but there might be other issues that you're concerned about, specific learning disorders, cognitive impairment, intellectual disability. And so that might be something where you want to refer for objective neuropsychological testing and really kind of specify, hey, I'm really concerned about this diagnosis of ADHD, so that they can know what they're looking for. As I mentioned, as a clinician, you certainly have the use of the rating scales of the Vanderbilt in addition to your clinical evaluation to make that diagnosis. But again, please feel free if you have questions or concerns to call our consult line to make a referral so that we can aid in the diagnosis as well. Now, if you have a diagnosis of ADHD, really the first line treatment are stimulant medications, and we'll talk about those in just a bit. But certainly if there's a concern for family history of cardiac problems, you might consider getting an EKG for your child. Most children and adolescents will tolerate a stimulant very well, but certainly if there is early cardiac mortality with first-degree relatives, I'd want to make sure that I get an EKG to make sure that cardiovascularly there's no concern. The one caveat in thinking about efficacy for medications with ADHD is that preschoolers, so I'm thinking children age 6 and younger, really behavioral therapy is both the first and the second line treatment before we start a medication. Medication is Ritalin and it's the third line, and really we want to make sure that the family has gone through 1 and 2 of behavioral therapy before we start a medication. Again, all of this is in the resource guide that is available online, and you can also get a copy delivered to you from the healthcare authority, who is our partner in kind of pulling this together. And then certainly make sure you're asking about sleep, right? I don't know about you all, but I know whenever I've had a night where I haven't been sleeping very well, I'm more groggy, I might be a little bit more irritable, and certainly my concentration is impaired. If you have kids that aren't getting adequate sleep and concentration is a big issue, we really want to make sure that sleep is doing well. We have good sleep hygiene and they're getting adequate sleep. To talk out of the other side of my mouth, the other complicating factor is that it's not uncommon for children that have ADHD to have sleep impairments as well. So that's for you as the wonderful clinician to kind of tease out and to determine what came first, the chicken or the egg, but certainly we want to make sure that kids are sleeping well. Also make sure that they're getting adequate nutrition and kind of taking care of themselves in that way as well. This is the Vanderbilt that I just showed you previously. In clinical practice, again, the efficacy for stimulants is just, I think it's like 1.0 compared to others. I think in psychiatry, it probably has the most efficacy of any of the medications that we do whenever we're working with children, and certainly they're very well tolerated. So really first line for children 6 to 17 is going to be a stimulant medication. Which stimulant might I choose, Dr. Coffey? That really can depend on a variety of different things. You might kind of consider family members' response to medications. It might also consider kind of what is first tier on your sooner care plan. I hate whenever they change it and they've done well on one and then they flip it to the other. That will happen. I apologize for that. I know that can be frustrating. But again, really in my kind of clinical role, I feel like quite often methylphenidate preparations like Ritalin seem a little less heavy hitting for whatever reason. And so I might start with Ritalin for my younger children. Adderall, Vyvanse, the kind of amphetamine salts certainly can be available for younger children. But in my mind, for what it's worth, feels like they're a little bit more potent. I have nothing to back that up. And I know there might be some child psychiatrists that are on this call, and please feel free to chat in and say, Dr. Coffey, I don't know what you're talking about. That seems to be my clinical experience. If it's a little one, I might start with the methylphenidate. Seems to be a little bit more wiggle room to kind of titrate that start low and go slow. But certainly if you were going to start an amphetamine salt, something like Adderall or Vyvanse, there'd be nothing wrong with that. Really second line too, if a child doesn't do well on one preparation, for instance, you start them on methylphenidate, immediate release, and that's really a problem. You can certainly try an amphetamine salt to see if they do better. Not uncommon that a child might have some difficulty with one type, but do fine on the other. And so you might consider that before you go to kind of second or third tier. The other thing that you might consider too, and again, we won't get into the kind of overlaps between whenever a child has had much trauma and kind of what that looks like with attention and concentration, but certainly we know that trauma and adversity can play a role in so many psychiatric illnesses. But also if hyperactivity and impulsivity is more of the kind of presenting factor, or if you're concerned perhaps that this might be ADHD with some kind of adversity and trauma that is kind of comorbid with it, you might consider starting with an alpha agonist, something like guanfacine or clonidine. Clonidine is often thought to be a little bit more sedating. And so certainly if a child's having hyperactivity, impulsivity, and having some difficulty sleeping, clonidine might be an effective medication to start at night. It too can kind of be BID dosing whenever that sedation wears off a little bit. And the other thing I'd add too is I know that I spoke earlier about avoiding polypharmacy. There actually is some good data to support that children that can't tolerate a higher dose of a stimulant medication but are still having ADHD symptoms like hyperactivity and impulsivity, the combination of the two, a little bit of a stimulant and a little bit of an alpha agonist, can be very helpful to monitor symptoms. And so that might be something to consider in your clinical practice. If you're like, goodness, I started this little guy on Ritalin 5 milligram BID. He's almost there, but when I try to bump it up, he gets kind of irritable. Adding a little bit of guanfacine or clonidine can kind of help with those residual symptoms. I will tell you that really, when you look at the literature of psychiatry, that's probably the only time that child psychiatry will recommend kind of a combo of 2 medications for one disease state. But this is one that does have some pretty good evidence. And I'd also say in clinical practice can certainly be very helpful for kids with ADHD. The other medication that we often use is atomoxetine. And I'll offer to you too, if you look at the research, this isn't necessarily the protocol that they will say kind of how to do things, but I feel like when in my own practice and in most child psychiatrists that I see, this is the way that we do things. And atomoxetine is often used for children that have more inattention or comorbid anxiety. It's a medication that can certainly be very helpful. It's not going to act right away like the stimulant medications. I will offer to you too that if you've had a patient that's been on a stimulant medication, sometimes it's harder to make the shift. Because parents know right away if the stimulant's working, it's kind of harder to know if the atomoxetine is taking some time. And so that does require some psychoeducation with families, the importance of taking it. For your stimulants, they might take what we call a drug holiday on the weekend. The atomoxetine or the alpha agonist, you really want to make sure they're taking it daily so it's building up in their system. The other thing that I'd offer too, just again, some kind of clinical pearls and special considerations. Adolescents with comorbid depression, bupropion or Wellbutrin can often be helpful. Bupropion is considered a 4th line treatment for ADHD symptoms, and I think can be very helpful for children that have this kind of depression, concentration, and then ADHD combination. Again, I think this is kind of where the art of medicine comes in. If you're wanting to follow clinical guidelines, if you have a child that has 2 disease states, you might go with the evidence base for each one. I'm kind of someone too that if I can kill 2 birds with 1 stone, I'd much rather do that because we know that medications can have interactions. We know that adherence changes whenever we're adding more medications. And so again, just a little bit of an insight of how I practice in child psychiatry, which certainly does have evidence, but there are other ways to practice. And so just putting this out there as well. As I mentioned, again, just to reiterate, ADHD and comorbid anxiety, atomoxetine can be quite helpful. And then that combined treatment that, quite frankly, we don't often see in child psychiatry. So I think it's important for you all to know this literature that's coming out to show that it can be effective. Okay, let's move on to talk about disruptive mood dysregulation disorder. If you've heard me talk about this before, I often talked about how I hate this diagnosis, and I think I've softened to it a little bit. It's still relatively new in the kind of diagnoses of treating child and adolescent psychiatrists. It really did come about because maybe 10, 15 years ago, the kind of diagnosis du jour for children was bipolar disorder. And what we found is that children that were diagnosed with kind of severe emotional dysregulation with bipolar disorder, as we kind of progressed and watched them, they didn't have bipolar symptoms as adults. So you all know, I know too, we think about our diseases in chronic disease states. It's kind of like if you were practicing and had a diagnosis of diabetes and then that changed into something else later on, you'd be thinking about, did we really get this diagnosis right early on? Same too, we're doing this in child psychiatry. And quite frankly, I think we're still understanding severe emotional dysregulation in children. I feel like DMDD is trying to capture what severe emotional dysregulation is in children, but it still is a bit of a challenge. Prior to this talk, I did another kind of literature review to see if there was anything new that was coming up. I'll show you guys a bit about a matched study, which is an acronym that has some in-office techniques that I think could be helpful. And I think does have some insights about kind of what is the etiology, what is the cause of DMDD. But the reality is that we're still understanding what this diagnosis means. And so what I'd offer with that is that if you have a child that has a known diagnosis of ADHD or anxiety or something else that's going on in addition to DMDD, first and foremost, treat that known diagnosis first. That's really what the literature supports as well. And we have tons of research and evidence around the treatment of anxiety disorders in children. If it's comorbid, tackle that guy first, you know which way to go, and then figure out what is contributing to the DMDD later on. So this is a bit of a busy slide, and this kind of reiterates a bit of what I was saying too. Most of the studies on DMDD are ad hoc. So they're looking at kids that had comorbid diagnoses of ADHD, but they are really dysregulated. And so we're kind of teasing apart all of this information from decades ago. The reality is that most of these kids go on to have a diagnosis, as you can see up at the top, of depression, anxiety, or ODD. And so in my mind, it feels like it's almost like a bit more of the extreme of these diagnoses. And so if you're seeing depression, if you're kind of seeing more anxiety, make that diagnosis first, as I mentioned, and really try to tackle that, because DMDD is still this kind of new beast that, quite frankly, I think we're trying to figure out what to do with it. I have my own kind of theories about what's going on there, but we'll see if I have some time you guys can question me about it and I'll let you know what I'm thinking. Okay, so DMDD diagnosis is really the severe recurrent temper outbursts that are grossly out of proportion in intensity and duration. Again, a developmental lens is very important here. Certainly a 3-year-old's tantrum is going to be different than a 14-year-old's tantrum. Maybe not. I don't know. I feel like adolescents are back in that pruning phase, just like toddlers were. But again, we want to think through a developmental age, think of the lens. They're often occurring 3 or more times per week, and the mood in between is really kind of irritable or angry. And so those are things that we're looking out for as well. The other thing, this moves so fast for some reason. The other thing is that it's been present for 12 months, 12 or more months in at least 2 of 3 settings, and it must be severe. The age of onset is before 10 years of age, and again, the diagnosis should not be made for the first time before 6 or after 18. And so there is kind of an age discrimination here, and again, we're thinking of severity of symptoms that just seem different than we might see with anxiety, depression, or even oppositional defiant disorder or ADHD. So I think the severity is really the piece here that we're very concerned about. I think I have like some kind of weird advancement on my slide, so I apologize. The other thing too, as I mentioned, we kind of have this looming is this bipolar disorder, and we certainly want to make sure that there's no history of mania or hypomania. So how do we know the difference here, right? Irritability is something that we see in mania. I think a big factor that I'm always asking about whenever I'm making this diagnosis is tell me about sleep. When we think about these kind of poles of depression and manic disorder, we're often really tuned into, are we having difficulty sleeping, decreased need for sleep? These are big indicators for me that might make me think, oh, is this more of a diagnosis of kind of a bipolar picture versus DMDD? The other thing too, making sure we're getting a real accurate family history and really asking about this, making sure that it's a true and kind of you feel very confident in the diagnosis of bipolar disorder. Hypersexuality, kind of grandiose thinking, rapid speech, and other things would be more symptoms I'd be concerned about. This might be bipolar other than DMDD. And again, DMDD cannot coexist with bipolar disorder. Again, it can't be explained by depression, PTSD, anxiety, or dysthymia. It can't coexist with oppositional defiant intermittent explosive disorder or bipolar affective disorder. It can coexist with depression, ADHD, conduct, and substance use disorders. Again, so if there is this comorbidity there and you have a child that you know has depression and has a diagnosis of DMDD, really first and foremost, treat that depression in an evidence-based algorithm and then see what's kind of continuing to bubble up with this DMDD. Again, just to remember, it's still a relatively new diagnosis. The current meta-analysis, quite frankly, recommends several medications from several different classes to be effective. What I'd offer for you too is that if you're starting a medication, and we'll talk about that in just a moment, which ones you might choose. If you're starting one and it's not really working, stop that one. Don't continue it on and add something else on it. Kind of think about another medication that might be helpful. DMDD is a tricky one, I think, for child psychiatry, for all of us as well. But as much as we can avoid polypharmacy, that's going to be helpful. Talking out the other side of my mouth, if you feel like a medication is helpful for targeting the anxiety symptoms and you're there, but there's still this irritability, you feel like the medication is helping the anxiety, isn't making the irritability worse, certainly appropriate to add something different. But I really think it's important for us to be judicious about use of medication with children. Again, not uncommon that I'm seeing kids that are coming to me on 5, 6, 7, 8 medications and still really struggling. This is just not appropriate. If we're on 5, 6, 7 medications and doing great, that's a different story. When you guys start seeing that, let me know, because I very rarely see that. I often see kids that are coming in on a multitude of medications and they're not much better. And so certainly want to make sure that we're judicious in our use of medications for children. We want to consider the symptom targets to guide treatment. Again, I think it just rubs me the wrong way because we really should be treating the diagnoses as opposed to the symptoms, but yet here we are. So just to put that on there too. Therapies really should address what they call as delayed attainment. I'm kind of curious about the role of DMDD and kind of our new ability to have constant gratification all the time. The fact that they're kind of addressing this delayed attainment and frustration tolerance. I think it's kind of ubiquitous in our culture. So I'm really curious about what that looks like in our children. It's more of a hypothesis than anything that is really well documented or researched yet. But certainly we know that therapies that address delayed attainment can be very helpful. There's actually a great research that was done kind of similar to what we see with cognitive behavioral therapy, where we have what's called like, exposure, right? So I'm afraid of getting in an elevator. I learned some coping skills before I get in that elevator. My therapist might show me a picture of the elevator first, and I feel my heart rate go up, and I use my coping skill to get better. Next session, she takes me to the elevator, and I'm standing before it, and I don't want to get in, and I'm using my coping skills. And then the next, I'm in the elevator and kind of gradually working towards that. Some of the treatments that treat DMDD are kind of similar. So thinking about something that might frustrate a kid, getting their PlayStation taken away from them. It's always great when DMDD really routes up whenever we're getting our PlayStation taken away from us. So again, kind of thinking about this too, and then giving the child the coping skills to kind of tune in, tolerate, and sustain that frustration. The reality is that as grown-ups, we model this for our children, and they don't often come with that skill set. And I am a firm believer too that we kind of have an environment that is currently letting them have access to everything all the time. And I do think that does something. I won't get up on the tangent on it too, but we see it in the research that delayed attainment can be helpful. CBT can also be helpful as well. Alderian play therapy, as well as interpretation bias training. I will offer, and if somebody knows about folks that are doing these therapies other than CBT in the Oklahoma area, you let me know. I don't think these are real mainstream in what's happening in Oklahoma. And so I will just offer to you that DMDD can be a little tricky. And so I feel you in that pain. I think it's hard. And again, your friendly child psychiatrists are happy to consult and talk with you. And in just a moment, I'll give you some kind of in-office techniques that have shown to be helpful for children that have DMDD. So how do we treat this? They're coming in, they're struggling. What kind of medications we use? Again, this is my big kind of just grudge against DMDD is when you look at the literature, it's like, use anything in the pharmacopoeia. That's not great practice. But the reality is that that's what we see. We're really doing our best to understand this diagnosis. When you think about treatment of aggression, kind of more physical aggression, again, we're often pulling from the research when we think of aggression for children that are on the spectrum. So potentially atypical antipsychotics that are FDA indicated, aripiprazole and risperidone. But the reality is that many clinicians are using either alpha agonists or stimulants, SSRIs, SNRIs. The atypicals I mentioned are either lithium. The irritability, often recommended again to try the atypical antipsychotics or stimulants. Because this is so broad, again, I want to offer to you that if you have a comorbid diagnosis of ADHD, of depression, use that medication that's indicated for those disorders. I think that's the best thing that you can do for the kind of evidence base for the child. And again, start low and go slow. If it's not helping, stop it and then try something else. Really do your best to kind of make sure you're not just adding on medication after medication, because that really can have side effects. And then we often get into the situation of, what's causing what? Is it a side effect of the medication? Is it the combination of the medications? So as much as we can, being judicious with medications and the treatment of DMDD will be very helpful as well. Okay, so I mentioned to you as I was kind of going through the research in preparation for this talk to see if there was anything new. Quite frankly, there wasn't a lot of new evidence on medications to use, but I did see this match study, and I'll be happy to kind of give it to our Osteopathic Founders Foundation if you want to take a look, that talked about some techniques that they were using in the office to support parents. I really loved this too, because when I think about, as I mentioned, the role of the caregiver and helping to model for children, helping to give them coping skills and language about how they're doing, quite frankly, I think that is a very helpful tool to be able to use. When I was reviewing this match study, I was also thinking about a very effective evidence-based intervention for oppositional defiant disorder, which is parent-child interaction therapy, or PCIT, which many of you hopefully have referred your younger children to whenever children have a diagnosis of ODD. The way that PCIT works is that the first kind of sessions are really just engaged with helping the parent to engage with the child. And quite frankly, what often happens is whenever the parent's more attuned to the child, they're spending more quality time together, symptoms get a little bit better. And many families do better just with that intervention in itself. And then if there are still struggles, what happens in the next thing is that we're doing more of these kind of disciplinary kind of timeout and other support so that the kids are knowing the structure and the function and kind of how things are going. When I was reading the match study, I was kind of seeing the same thing. And I think it's important for us to have kind of tools and interventions that we can do in office to kind of help parents. I know you guys do this too, right? If it's kind of some psychoeducation around normal development, thinking about little babies getting a little stranger anxiety, totally normal. I'm thinking about younger kids when they get a little bit worried about the storms that are happening or a little bit nervous about going to school. Sometimes just normalizing that, hey, a little bit of anxiety is part of life can be helpful in kind of relieving anxiety for the child and the caregiver. And so these are real things that we can do too. So I do think in the office, kind of engaging parents, letting them know that you hear what they're saying, doing some of those active listening, recognizing too that the parent might also be struggling with the behavior of the child, and not to shame or blame the parent, but to also recognize like, hey, this is probably stressful for you. Tell me how it's going for you. What are some things that you've tried? Understanding the behavior is very key here too, right? I'm really big about this with my trainees as well. He tells me he's real aggressive. Okay, well, what does that mean, right? I'm quantifying what aggression means. It's happening every day that he's slamming the door. 3 or 4 times a day, he's punching his sister. Every 2 weeks, he yells at me. What aggression means to the family is going to be different from family to family. And so certainly quantifying the kind of severity of it and the frequency of the behavior can be very helpful too, because that gives us some tangible things to work with and to make sure the frequency is better and to make sure that the severity is lessened too. Again, one-on-one time is key. When I first started practice here in Oklahoma, I used to have a lot of beach balls. And one of the things that I would do is I would give a beach ball to the family, and I would encourage them just to kind of play a little bit together. I have my own children too, and I often tell families as well, like, put on some music, do something else that's fun for you. I mean, full disclosure, playing Candyland with my 3-year-old was not the funnest thing for me. Playing Candyland, listening to some jazz or some music that I like, much more fun, right? And so making sure that it's an enjoyable time to be together, having them kind of think of something that they want to do, having them go to an arcade for 4 hours might be a little, A, financially might not be possible, B, it might be a lot of time, but playing catch in the backyard or playing basketball for 10 minutes, starting real slow and kind of starting small can be very helpful to kind of build that attunement and that relationship. The other thing that we often talk about too is the role of praise and scaffolding, right? You all know this, we know our child development, we recognize that we wouldn't expect the same thing out of a 14-year-old as we would as an 8-year-old. We want to kind of manage parents' expectation and also recognize whenever kids are making their way that way. I too have to do this. My expectations for cleaning the kitchen are much different than my children. If they're trying to get that way, I'm going to praise them. If I was scolding them because they didn't do it the way I wanted to do it, how much more do you think they're going to do it? Not very much. But again, recognizing our role in kind of scaffolding, getting them there is very helpful. And to be mindful too, goodness, I feel like I'm going to blank on the number that I've seen in the literature, but we know that it's not uncommon that children hear the word no, that they're not doing things well, they're trying their best and they might just not be getting it right. There's often a lot of research that says that it takes, I want to say it's 5 or 10, but for whatever it is, it's like, we'll say 5, that it's 5 positives to kind of rule out 1 negative. So I think as much as we can, praising kids whenever we see that they're doing what they want to do can be very helpful. I try to do this in the office too, again, kind of modeling for parents. Like if I'm seeing a child with their sibling and I see that they're sharing the pen, I would explicitly say that, oh, I love how you gave your younger sister the pen. That was very helpful for you. So that they're using those opportunities too to kind of set the expectations of what they want to see. Sometimes, quite honestly, we forget that. And I think it's really helpful for us to kind of do this in the office too. What I'll offer is that I'm going through this again, the document itself, like the study that this came out of is real explicit about what this looks like. And I highly encourage you to take a look and try it in your own practice too. Active ignoring is a good one. It can be kind of challenging for kids that have issues with attachment and other traumas. But again, if it's not a safety concern, to be able to kind of just let them know, like, I hear what you're saying right now. I want you to be able to use the tone. And when you're ready to talk with me without yelling, I'm happy to talk with you, and then attending to something else. Again, so these are things that you can both engage and talk to parents about, but also do it in your own practice too. And I think, again, just some in-office techniques can be very helpful. Again, giving effective instructions. I don't know about you all, but little people are not really great at following a 3-step command. I'm going to say it. Sometimes my husband isn't good about following a 3-step command. Like, I love him very much. He's my partner and he's the best. But I think also being mindful of that too. We all have a lot going on in our world. And so like, just to kind of set expectations for families too, if you're telling your kids, go get ready for school, think about what that entails, right? So my You know, my 9-year-old getting ready for school. It might mean brushing her teeth, finding her socks, putting on her socks, finding her shirt, finding her school shirt. Like it is like 10 or 20 different tasks that are occurring in that big instruction. It can be helpful for parents to know that they might need to tease it out. Again, and hopefully we'll get there. Again, that scaffolding to get there, but effective instruction can be very helpful too. And the reality is that sometimes we need these types of explicit instruction as parents. All kids are different. I know that as well, having 2 kids that are markedly different. Every kid might need a little bit different things. Rewards can often be helpful. You know, thinking about kind of I'm laughing because I feel like I bribed my kids to have a good vacation. I was like, what do you want to make sure this vacation is going to be great? And I'm not below bribing my children to have a good vacation. That being said, I think rewards can be a little bit of an incentive. All of you that go to work get a reward for going to work. You get paid. I think that probably makes us feel good whenever we get reimbursed for what we're doing. The reality is that kids are no different. We want to make sure that they're developing their skills and there's some intrinsic reward. But if we can kind of help them to get there with a little bit of a sticker or something else that just kind of helps them to achieve a goal, I think that can be helpful. There's more to talk about this and kind of a broader spectrum, but it is something I think we can do kind of in the meantime. And again, the match studies saw specifically for DMDD that can be helpful. Timeouts can be something that we're doing, making a plan, recognizing that we might know some additional triggers that are occurring. Well, if you know that your kid is getting really stressed out every time you go into Walmart, I might be asking, do you need to bring the kid into Walmart? Making sure that we're not setting our children up for failure, for us for failure can be helpful too. And again, that scaffolding. Maybe we're just going to check it out for a couple of minutes, keeping that in place too. The daily report card can be helpful. What gets paid attention to gets paid attention to. And so again, I always like to ask about kind of what the goal for treatment is. Quite often for kids with DMDD, it's a decrease in severity and frequency of these outbursts. Let's kind of make sure that we're tracking them to make sure that things are getting better. And in the match study specifically, they talked about some booster sessions. So those are just a little bit of things to be thinking about that you might want to incorporate whenever you're seeing kids that are coming in with a diagnosis of DMDD. Highly encourage you to take a look at the match study to see if it might be something you want to incorporate more into your practice. Okay, let's move on to depression. Depression is common in children, common in adolescents. Throughout the COVID pandemic, we saw a marked increase of depression. I feel like it's really increasing in our adolescent population as well. And quite frankly, suicide remains one of the leading causes of death for adolescents, and so we don't want to miss this. I think AAP actually recommends screening for this in all of our kind of child and adolescent patient visits. It might be adolescents, and I apologize if I'm not getting that correct. There's actually been studies that show that regardless of where you're practicing, if it's peds endo, peds ortho, that screening can be very helpful to make sure that kids are getting what they need. And again, depression is one that we just really should be screening for. We should normalize that it's okay to not be okay. We should talk about these things. You guys are doing well child check. Emotion is a really big part of our overall health. And so we certainly want to make sure that we're talking about it. Depression, again, continuous feelings of sadness and hopelessness, although with littles, they can be more irritability or even temper tantrums. So again, is this DMDD or is this depression? They can have kind of low energy, increased sensitivity to rejection, changes in appetite and sleep, impaired concentration, somatic complaints can be a big one. We see this quite often, kids with headache, tummy ache, problems like this. And again, suicide, worthlessness, and guilt can be there as well. I put this up here. This comes from our youth risk behavior study. As you can see here, the 10-year trend description by sex, the percentage of female and male students who experience persistent sadness, a whopping 57% of females reported. That's bonkers. That is really, really high. I think if you're really thinking about how we're going to target screening for our population, we should be concerned about our young girls that are coming into our practice, certainly concerned about our males too, but it's really increasing nationally in our female population. You can see here too that up to 24% of females actually made a suicide plan. It increased from 15% in 2011 to 24%. This is happening. We have to start talking about this, and we have to make it a normal part of practice. I certainly know when I first started my psychiatry residency, quite frankly, it was hard for me to ask about suicide or thoughts of death with my adolescents. The more you do it, the easier it gets. These symptoms are coming. There used to be a concern that if we talk about it, we're planting the seed. The reality is that that's not happening. We're actually giving an opportunity for many kids to kind of to feel heard and to kind of seek help and support. And so please make sure you're asking your children and adolescents about depression and suicidality in your practice. There's a lot of rating scales that can be used. Again, as I mentioned, I'm a fan of the free ones. I love the Center for Epidemiological Studies of Depression for Children. It's validated for kids as young as 6 up to 17. For our adolescents, you can certainly use the PHQ, and there's an adolescent version as well. I like this ESDC. I think it gets kind of more specific. And again, it's free to use online, and can really kind of ask about some of these symptoms that we see that are more specific for children and adolescents. As I mentioned, therapy really is kind of first and foremost a treatment. Evidence-based therapy, though, is really indicated. And so you might consider CBT. Cognitive behavioral therapy is often considered more effective than just supportive therapy alone. That being said, if I'm referring a child for therapy and things are getting better and it's supportive, that's great. You know, the proof's in the pudding. I would probably be checking that CESDC if I was a primary care doc, having them come back every 4 to 6 weeks, just kind of checking in to make sure things are better. Again, you can use the rating scale for doing this too. And then if things aren't better or if things are really severe, important to know that SSRIs can be helpful in treatment of depression in children. CBT is the most studied non-pharmacological intervention, but there are positive effects for SSRIs. And the TADS clinical trial of adolescents really showed that the combination of the two, so an SSRI and CBT, is really most effective for teens. So the combo can be really, really great and helpful for teens that are struggling with depression. We want to consider the effectiveness, safety, response in the patients. Again, as I mentioned, SSRIs are the safest. The two that are approved, FDA approved for treatment of depression in children and adolescents, are fluoxetine and escitalopram or Lexapro. And again, important to let patients know that it can take 4 to 6 weeks at the optimal dose until improvement is seen. So we start low and go slow, but certainly if we're at 40%, 50% better on 5 or 10 of Lexapro, I'm going to bump that up because remission is certainly possible with treatment of SSRIs. And then what we often recommend is continued treatment for 6 months to 1 year after recovery of symptoms, depending on how many episodes of depression somebody had or how much severity there was. That's going to determine my decision making too. Certainly, if there was a suicide attempt, multiple depressive episodes, I'll likely continue the medication for longer. If it's a mild episode, medication was very helpful. They were in therapy. Coming off of a medication is certainly an appropriate thing to do with families kind of treatment, permission and agreeableness too. For SSRIs, the big one we always want to worry about is kind of increased suicidality. Well, Dr. Coffey, why are we even treating the depression with a medication that increases suicide? The reality is that SSRIs don't increase suicidality. We actually saw whenever the black box warning came out, an increase in suicidality. There was a marked decline in the administration of SSRIs, and suicides kind of really shot up. But it can increase kind of suicidal thinking. What that means in my practice is that I'm having the conversation with the family member that if we're starting this medication, if you're having thoughts about not wanting to be alive or suicidality, I want to know right away so that we're treating you okay and we're just monitoring it. We also know too that it can have this kind of manic switch. This can be a little tricky because some of our medications can be a little bit activating. I feel like fluoxetine or Prozac can be a little bit activating in littles, and that's why I like to start low and go slow. So teasing out is it's more kind of activation or mania can be helpful too. But certainly if there's a strong family history of bipolar disorder, I'd be on the lookout for that as well. Other things you see, akathisia, agitation, kind of runs the gamut. I feel like the big ones that we often see is a little bit of headache and stomach ache that gets better. And again, also just important to kind of start low because the higher the dose, the more likely that we'll have side effects as well. You can kind of see here the other side effects that we consider there. Again, just to kind of put the 2004 FDA black box warning that's there, important that you're having this informed consent with family. But in clinical practice, just making sure that families are coming back in and telling you if you're having these symptoms. Okay, so we'll end with anxiety disorders. Anxiety, I think, is a really important thing, again, that we saw much increase throughout COVID. Quite often, many of us that work with children feel like anxiety often is misdiagnosed with ADHD and other things as well. So be on the lookout for anxiety disorders because it certainly will come into your clinical practice. You can see here the variety of anxiety disorders that you might diagnose. Again, not uncommon to have comorbidities. So you might have a child that has both kind of generalized anxiety disorder and a specific phobia. They like to come in pairs for whatever reason. So be on the lookout for that too. The other thing is that anxious little ones come from anxious parents. And there's actually been some great studies through Yale that show they've actually done research that just treats the parents' anxiety and the kids get better. So again, for you family docs or pediatricians, those have been working for families for a long time, having those conversations, making sure as caregivers that we're taking care of ourselves really does benefit children. And really great studies have shown that too. I just think that's remarkable that you can have a child that has anxiety and treat the parent and the kid gets better. Just keeping that in mind too, if the kid isn't getting better and parents' anxiety is really bad, we probably need to have conversations about the parents' anxiety too, or the caregivers. Anxieties too. I joke, you guys are probably getting sick of my joke, but I've never had a 6-year-old come to me and say, man, Dr. Coffey, like I'm just super worried about school starting. And, my mom's kind of stressed out because she's having issues. And I think my parents are having a little bit. They never come in and use their words to tell me what's going on. They just don't. Instead, they're clinging to their parents. They're getting into fights at school. They're super irritable. And so anxiety just looks different with little people than it does with grownups. And we have to keep that in mind. And so quite often they might be more irritable, right? They might need a lot of parental reassurance. School avoidance is a big one. We often think of school avoidance as more of kind of the extreme of anxiety. Somatic complaints, this is a big one too. So you have a kiddo that's coming into your office sent home by the nurse every day with a headache. You've done a good workup. You don't think it's allergies or eye problems or anything. Think about anxiety, this kind of midline issue of headache and bellyache and other problems we often see with anxiety. Great opportunity for psychoeducation about the mind-body connection here. It can be really helpful to kind of make sure that we're, ruling out anxiety whenever kids are coming in. Hypervigilance, reactivity, catastrophic reactions, really needing a lot of reassurance from family who see with anxiety disorders as well. Again, big proponent of free things I can find online that are helpful. And the SCARED is another great one. It's a great acronym. It's the Screen for Child Anxiety Related Disorders. What a great acronym for an anxiety disorder. Again, it's free online, and it's really helpful because it kind of breaks down to the specific disorders that are there. Again, rating scales can be a helpful tool. It certainly isn't in place of your clinical conversation and evaluation with the child and the family. This tool is great because there's one for kids and one for parents. Always like to compare it to kind of see what the parent is seeing and what the child is seeing as well to kind of guide treatment and how things are going. Again, for anxiety, really cognitive behavioral therapy, a specific cognitive behavioral therapy is considered the first line evidence-based treatment for anxiety disorders. Again, if I have a kid that's anxious, they got some supportive therapy, things are getting better, not too concerned about it. Have a kid that's super anxious, has been in kind of a not really evidence-based therapy for some time, I'm going to make sure that they're in an evidence-based intervention. If therapy isn't successful, the combination of therapy and medications can be very helpful. And as I mentioned, studies have shown that parental anxiety improvement can help kids be less anxious too. So talking about that as well. I'm happy to report that more recently, when I was updating this talk, that Lexapro or escitalopram is now FDA approved to treat generalized anxiety disorders in youth. So that's kind of a new development that I just learned in preparation for this talk. In the past, aloxetine was the only one that was approved for non-OCD anxiety. That being said, it's not uncommon that we are using medications like sertraline, which is actually approved for OCD. It has some of the most rigorous studies for treatment of anxiety disorder. I put in the FDA approval because certainly as clinicians and as parents, that can often guide treatment. Parents are wanting something that's FDA approved. That being said, many of our diagnoses and treatments have a lot of research to support it. But as I'm sure you all see quite often, pharmaceutical companies don't go on to get the FDA approval because they already have it. But there are, again, first line is an SSRI for treatment of anxiety disorders. Start low and go slow. These kids have a lot of side effects to medications. And so if I'm starting at 50 of sertraline for a 6-year-old and he gets a tummy ache for it, forget it. I've kind of lost the buy-in with it. I'm going to start real low, go slow, and kind of target to treat symptom remission. So this comes from Walk Up, talks about evidence-based for children, that really combination treatment is the most effective with an 80% response rate. SSRIs and CBTs are most effective, and the placebo was 25. In addition to ADHD having stimulants being super effective, anxiety treatments with SSRIs is kind of just right behind it. SSRIs can be super helpful for treatment with anxiety. Don't avoid it. If it's needed, if it's severe, if medication is not helpful, SSRIs can be really helpful for kids and really, in many instances, life-changing. They just feel better, that anxiety is treated better. They're going to school, like a veil has been lifted. So don't feel like you shouldn't use these medications. They can be real helpful for kids with anxiety. Again, start low and go slow. Consider increasing after about 4 weeks. Give it about a year or so, coming off during a low stress period. Again, considering family history. Some kids might need to be on it lifelong. Others might do okay if they're able to come off of it. So just to kind of wrap up too, again, if you have a kid that's coming in, making sure they're getting that real good behavioral therapy, start low and go slow, avoid polypharmacy, and make sure that we're getting the consent and the assent for parents and monitor for side effects. And again, the BID dosing. If you need more help with diagnosis or understanding what's going on, please know about our pediatric behavioral and emotional health tele-echo. Meets every Tuesday at noon. You get free CME from going there, and it's a great opportunity to bring a kid there to kind of get some really wonderful support from Dr. Deshpande, Dr. Mazur, who's pediatric neuropsychology, pediatric psychiatry, pediatric psychology, and a pharmacist. You can't believe this team to kind of better understand what's going on. And if you're in the office and you kind of need somebody right away between 8 a.m. and 9 a.m. till 5 p.m. Monday through Friday, call our child psychiatry access line. So this is a wonderful partnership with DMH and Dr. Tessa Cheshire, who's the medical director for OK CatMap. And we're available for you. If you want to give us a call, we will staff a child with you. We'll give you some recommendations for an evidence-based intervention in your area, medication recommendations, and all the things at your fingertips. This too has some CME credits that are available online. OK CatMap is a great resource for you. Your friendly child psychiatrists know that you guys are doing amazing work out in your clinics, and we want to support you and kind of know ways that we can help you to help kids that you're seeing come into your office every day. So those are a few that are available for you. I will stop now and entertain any questions that you all may have. And Adrian's pulling it up for me. And okay, and I'm gonna pull, so it says, regarding feelings of sadness and hopelessness in adolescents, have there been any studies to show how being involved in church activities or believing in God affects these feelings? So that's a great question. And what I'd offer is, I don't know in specifically with regards to those symptoms, but what I will say in regards to kind of all overall emotional health, connection with community, sports, other activities really aid in resiliency. And so certainly, I think that could be very helpful, kind of depending on the patient and the family. And I think that's a great question. Thank you so much for mentioning that, Patricia. I do think it's helpful to have a holistic approach and make sure that we are asking children and families who their supports are, what that looks like. Sometimes doing some motivational interviewing. Quite often, it's not uncommon that kids kind of start shying away from these things when depression is stepping in. You as the clinician can be kind of asking about that. I always joke with my patients that I'm writing in the chart so that the next time they come in, I'm going to ask them about, have they started painting? Have they gone to church? So that they too are kind of getting that feeling of support whenever they engage in these community activities. That's a great question. So I will just extend my gratitude for all of you that took time out of your busy week to come be a part of this call. Thank you to the Osteopathic Founders Foundation for giving us the space to have these meetings in the evening. I know that you guys are very busy and just really appreciate all that you guys do. We're here for you. Call that OK CatMap line. I'll also give that to you all too, the way to register and to call. It takes a village. I'm really happy to be a part of this osteopathic village and really appreciate the opportunity to work with you all. So thank you guys so much for your time.